I just wanted to welcome everyone to now our second annual Hand Surgery CME Symposium here. This year, we are entitled this one All Things Tendon. So we trying to come up with topics we think that would interest a wide audience, things that are common, things that people see in their practices and daily lives regularly, to try to really delve into these topics in a little more detail. This is just the mission statement of our practice, of our group, and we want to provide a comprehensive, cutting-edge, patient-centered care for the treatment of injuries and disorders of the upper extremity and peripheral nerve, and that really fits with the goal of this symposium that we're putting on here. Is we want to present really, in addition to what we do, but we want to really highlight the most up-to-date, current information that's available on these topics, and to really help the general community as much as we can. And then obviously there's some procedural things we have to go through. This was planned in accordance to all the bylaws of the Nassau University Medical Center and all the details we have to put up, the accreditation details to receive. And everybody will be receiving 4 Category 1 CME credits for this, which is nice. Obviously, we have no disclosures as all the speakers. Everyone will give out their individual disclosures, but I personally have none. And again, I have no disclosures. I have to put up this slide. And we wanted to say a big thank you to our sponsors outside. They definitely, in addition to helping us with our daily practice lives, and these are all products that we use on a regular basis. They support our endeavors, our educational endeavors, and we can't say enough thank you enough for all that. So please, especially during the break times, feel free to visit the tables, talk to them. They're all very nice people, and they have a lot of interesting stuff out there. So please do that. And then finally, something that is important for us and for you to receive the proper credit, you have to complete an evaluation for each speaker. It's a little cumbersome, I know, but that's the rules. There should be an individual form to fill out, pre-labeled, with each individual speaker in the packets. So please, as we're going along, please fill those out. And I will remind you throughout the day to do that. So if you could please do that, and then at the end of the day, hand them in, and that would be great. I wanted to take a few minutes to just talk about something before we officially begin. And the reason why I wanted to talk about this is because I came upon this idea a lot as I was researching for my own talk. This was a phrase that I kept running into in a lot of the papers that I was reading, the concept of regression to the mean. And I wasn't really certain personally what that was, so as I looked into it a little further, I thought it might be worthy of a mention for everybody. So what is that? It's a statistical phenomenon that occurs when we make repeated measurements of 2 imperfectly correlated subjects. It's a phenomenon that exists across multiple arenas, not specifically medicine, but it applies very well to what we do. Essentially, what the theory postulates is that any individual measurement you make has the possibility of having a random error. And when you make repeated measurements of the same subject, extreme values or outlier values are usually followed by a less extreme value. And what that means is if somebody comes in, essentially, what they're saying is somebody comes in severe pain, it's likely that the next time you see them, they're going to be in less pain. And that has nothing to do with what you do or don't do for them. This is just a statistical phenomenon. So essentially, we choose these patients for being abnormal. So there's patients that have high blood pressure or anything else, and they have some abnormal value, and that these patients will statistically tend to improve over time naturally without doing anything. It's essentially a get better anyway effect, or a benign neglect effect. And this is a very true phenomenon that occurs. And this basically what can happen is this will lead or can lead to inaccurate conclusions regarding the cause and effect of certain treatments. And this has been shown to be true. So some examples, it was initially described by a British statistician in the late 1800s. And what he did is he looked at the average heights of parents and children. And he found that if you have very tall parents, so parents that are taller than the average height, if you take their height together, their children tended to be shorter. And if you had shorter parents, their children tended to be taller. And as they looked at this phenomenon, they said everyone tended to slide over time towards a mean height. And eventually this concept got titled Aggression to the Mean. So this is similar to, say, if you have within subject variability between measurements of blood pressure, you say. So you measure someone's blood pressure, it might be, if you measure high, it measures high 1 minute, you measure it again a few minutes later, it's lower. You measure low 1 minute, you measure it a few minutes later, it's higher. And whether that's because some just statistical phenomenon that occurs, or sometimes you have people like, for example, that you have a cold, and you suffer through this cold for a week, and finally they say, I feel horrible, I'm going to go to the doctor and get antibiotics. They take antibiotics, and then magically their cold gets better. Well, is their cold getting better because their cold just gets better on its own, or because they took the antibiotics? And nobody knows, but everyone in their own mind says, well, I took these antibiotics, and it must have gotten better because of them. But that's not necessarily true. Another example I ran across a lot was red light cameras or traffic laws. So a lot of times they will have like a place where we find an intersection that has a high number of traffic fatalities or accidents, and they'll put up a red light camera. And they'll say, well, and then they'll measure the number of incidents that occur at that intersection in the following year, and it'll go down. And they'll say, well, look at this, we put up this red light camera, and it worked. Everything was great. But the likelihood is that if you just did nothing and looked at the same intersection a year later, if it was a high year, it's usually followed by a low year. So regardless of what was done, the numbers would probably go down on their own anyway. And what's even more interesting is if you look at these graphs on the right, the top one was taken from a paper that looked at interventions for osteoporosis. And just to cut to the chase, the far left of the graph is the 0 time point. The far right of the graph is the 2-year time point. And so they looked at all patients, they gave them either 2 different interventions for the treatment of osteoporosis. And if you look at the graph in the middle, it either peaks or valleys. And so the peaks are the people whose bone density increased at a year. And then at 2 years, it went down to the mean. And the people that had their bone density decreased at a year, despite the intervention, went back up at 2 years later. So regardless of what you did, and regardless of what happened, in 2 years you arrived at the same place. And that's kind of the idea, is that no matter what you're doing, a certain amount of the effect of what we're doing will get better on its own anyway. And for example, the one below it is a paper that came out in 2010 looking at the treatment of low back pain. And they looked at all these different types of interventions. It was a big meta-analysis. And regardless of what was done, people did pretty much the exact same for low back pain. And so it's a phenomenon that looks across multiple venues. So why does it matter? It's because we have cognitive bias. So we all see patients and do things to them and help to try to help them. And the idea is that we have this bias and what we're doing is making a difference. So can this cognitive bias we have cause us to misinterpret these effects? And that we can have inappropriate conclusions as to how we're treating the patients, as to how we evaluate studies. And a lot of people believe that the placebo effect really is simply regression to the mean. So there really isn't much, this placebo effect actually is very small. And what we're really evaluating is regression to the mean. And so there's also third-party commercial biases, so papers that come out that tout this is the next best thing since sliced bread. Well, if you look at the author, the author is supported by X and Y company, and maybe the reason why they're so hot to trot on is that somebody's benefited. There's some secondary gain going on. And it also calls into question the idea of, when you see studies where they say, well, this intervention was appropriate only for this certain subgroup. So, well, maybe that's the subgroup that got better on its own. So I just thought it was interesting to put a lot of what we're doing into context. So how much of this placebo effect is really statistical regression? And as it stands that people who tend to score the worst, people that tend to have the most pain or have the worst numbers initially, have the highest placebo effect. And that makes sense if you think about regression to the mean, is the people that have the highest initial values tend to drop down naturally towards the mean. So what do we need to do? How do we reduce this? Well, first of all, we should be aware of it when we're evaluating things, that it's a group phenomenon, so it's a statistical phenomenon and not a physiologic phenomenon. So it doesn't necessarily describe well what's happening to the individual, but if you're looking at it at the broader scope, it makes sense. The idea is you really should look at something, and we need to have sequential testing over time to give you more, so an average value is much more accurate than an individual value. And if you look at, and trials really need to be prospective, so you need to have a control group and an intervention group that are occurring in parallel, because theoretically regression to the mean should be happening at the same time to the same degree in both groups. And that's that. And so that's something when you're evaluating literature, that's something you should be looking for. And that was it. So I thought that was interesting. And I'll touch on it a little more in my own talk. But anyway, thank you. And so thanks everyone.